experience in dealing with patients who had a posterior polar cataract who ended up having an open posterior capsule. There are different strategies of management depending on at what stage you actually get it. So we all know the fundamental pathology in a patient with a polar cataract is three things. You have an abnormal opacification at the posterior pole. You have an abnormal adhesion between the posterior pole and the posterior capsule, with or without an inherent weakness in the posterior capsule. So this is the triad that causes. And therefore, being able to emulsify the nucleus with safety without creating an opening in the PC remains a challenge in itself. And I think what we need to know is that almost always the opening in the PCR is created at the time of the surgery as a result of manipulation. Unless if proved otherwise, that means if you see it preoperatively on the slit lamp with retroillumination, where you see the typical cuts opening in the posterior capsule, or on UBM. So you basically almost always have a weak capsule, and some manipulation at some point in the surgery has created that typical break that comes up. So this is a case in which you need to see that when the nucleus is being emulsified, you see this kind of round opening there. Now this is not an opening. This is just a condensation in the posterior cortex. And unlike that, in this particular case, when the surgeon is emulsifying the last bit, can you see what's happening in the posterior pole? You have the typical fish mouthing of the posterior capsule, the splaying backwards of splaying opening. And that actually indicates that there is an opening in the posterior capsule. It still doesn't indicate that vitreous is disturbed. If there is no vitreous disturbance, with great care and caution, if you keep the irrigation only in the anterior chamber towards the angle, you can, with aspiration, remove the cortex. And for the last bit, you can also use a visco-based aspiration with a drop-wise flow of Simcoe, right? Now I show you and once you're done with that, then you go ahead and place the IOL, and I'll come to that in a bit. Now this is a case of an NS2 polar cataract. The nucleus disassembly and nucleus emulsification was completely inconsequential. When the surgeon moves on to removing the cortex, towards removal of the second half of the cortex, one notices that underlying this is a typical opening in a polar cataract. Now this typical opening appears like this. It appears from one end of the equator to the other, like two parallel lines, like a little ellipse, as you can see here. What you do at this point, as you've seen here, is you don't remove your irrigation, but you do a visco-BSS exchange. This prevents shallowing of the anterior chamber and herniation of the vitreous. Now if you've got a stable hyaloid, you can still manage to put even a one-piece IOL in the confines of the so-called what's left of the bag. You can see here the leading haptic is gone into the bag. You turn it at right angles to the opening in the posterior capsule, and you can quite safely put the IOL in the bag, after which, of course, you don't have too much of rocking motions. Neither do you have too much of stromal hydration. You want things to be gentle. Just clear out the visco in the anterior chamber, and then you can proceed. Now here's the next case is, oh, sorry, where's it gone? Sorry. So, no, the next. So this is a case of, this is another case of an NS2 polar cataract. As mentioned even earlier, the technique to be performed here is not a hydrodelineation, but a hydrodelamination. Having done that, very often they are soft, so the entire nucleus is just mobilized and aspirated and foot pedal to without almost any energy. But as you can see, towards the end of the nucleus management, there's a splaying backwards of the posterior cortex. This makes you realize that there is definitely an opening in the posterior capsule. You do a visco and a BSS exchange, and despite doing all this and then bringing your phaco probe out, there's a further enlargement of the PC opening. This means the vitreous is disturbed. You then proceed with a limited anterior vitrectomy, first in the wound, then in the anterior chamber, then in the central area of the rent. Now once you've cleared the vitreous in the area of the opening in the PC, which is visible to you, then you can go only with the suction mode of the cutter, put off the cutting mode, and you can aspirate the cortex. Should you have any more further disturbance of vitreous, you go ahead in the cutting mode, clear a little more of the vitreous, and therefore in a circumferential manner, you can go ahead and clear the entire anterior chamber of, now you don't have vitreous, you don't have cortex, and then you can go ahead and place the IOL in the confines. Ideally, I guess a 3-piece IOL would have been ideal here. This particular case, the surgeon, while doing a hydrodelineation, noticed a pupillary snap. That is more common in a harder cataract where hydrodelineation itself is challenging. The surgeon at this point decides to actually, with the help of 2 instruments, rather than having this nucleus fall, picks it up and mobilizes it into the anterior chamber. under a lot of dispersive OVD, the surgeon then proceeds to emulsify the nucleus in the anterior chamber. At this point, you're not using an IOL as a scaffold, but since the pupil is small, the iris itself is used in a kind of way as a scaffold. This is a technique, okay, after which, again, with care and caution, using the irrigation actually as a retractor as well, the residual cortex is removed with ease, with no vitreous disturbance. The last bit again removed under viscoelastic, after which, but what I'd like to add in this particular case is, today I don't really think that if you've got a cataract of a moderate density, bringing up into the AC and emulsifying it in the anterior chamber is a safe thing, because no matter what you do and whatever viscoelastic you use, the kind of energy that you're going to use in such close proximity of the endothelium is likely to damage it. So I feel that if you have a nucleus that's dropping, I'll show you in the next case, it's probably best to just let it go. So here's a case of a NS 2 to 3 cataract. Now in the harder cataracts, what you need to know is when you do a hydrodelineation, you need to use a significant amount of force to get that wave going to delineate your endonucleus. And sometimes that can accidentally go into the subcapsular plane. Again, during nucleus disassembly, you do not want too much of a lateral separation. And I think you do a lateral chop in situ, try and get one fragment created which you remove. That gives you the ease of then rotating the rest without too much of manipulation. So here the surgeon then proceeds with trying to downsize and emulsify this rather hard cataract, and he gets through more than 4/5. Once you're getting the second last fragment out, gradually maneuvering it in the safe zone to emulsify it, the surgeon then notices a around 1 o'clock, a clearing of the PC, a red glow, and in front of your eyes, that fragment starts to drop down. Now, at this point, the surgeon puts in some more dispersive OVD to keep the vitreous from herniating and reducing your settings, bottle height and all, and you go ahead and remove the last fragment. You put in viscoelastic, again a fluid BSS exchange, and despite doing that, the surgeon notices that there actually is a vitreous disturbance. Now you proceed in the same manner. You go ahead with a limited anterior vitrectomy, and in an ideal scenario, putting a 3-piece IOL in the confines of the ciliary sulcus. So again, the vitrectomy to clear the vitreous, the suction mode to remove the cortex, and at the end of which viscoelastic is introduced, HPMC, and because we didn't have a 3-piece IOL, a rigid lens is placed in the confines of the sulcus. What's important here is you're looking at 1/8 or 1/10 of a hard fragment that's gone behind. In our center, we've tried to have it removed at the same sitting because we find that the post-op inflammation and pressures are going to make matters much worse. But what's very important in these cases is that you make sure that your IOL is stable, for which you have to make sure that your sulcus is stable, your zonules are stable, and you suture both the side ports and the main incision, augment the block, and hand it over to the VR surgeons, yeah? You don't want a soft eye because when they put the ports in to go in and remove those fragments, you want a tight eye, okay? This is a case of an eccentric polar cataract. All polar cataracts are not necessarily central. I haven't seen too many of them, but I did get this one. Hydrodelineation continued, and a lateral chop in situ is performed because it is a choppable grade of a cataract. And since it's very soft, the surgeon didn't bother making too many more fragments. Attempts at bringing each half out one after the other without any rotation, and can notice that in line with where the polar opacity is, there is an opening in the posterior capsule back there. The surgeon, with great care and caution, reducing all your settings and under a OVD cover, finishes removal of the nucleus, after which it's a good idea to stain and delineate your vitreous using 4 milligram, non-preserved triamcinolone, okay, which comes as 40 milligram per ml. You take 4 ml, dilute it and use it. Do a cut with the cutter, cut all the vitreous with the suction, or then with an eye, remove the rest of the cortex, after which the procedure is the same, yeah? Now, because of the inherent fragility of the posterior capsule, it's not such a great idea to do a capsule polishing. It's safer to do a YAG at a later date. Now, the surgeon here proceeds with polishing of the posterior capsule and ends up resulting in a ragged rent. Now, whenever you have a ragged, irregular opening in the posterior capsule, it is advisable that under a OVD cover, with the use of a microrhexis forceps, one can actually convert that ragged opening into a regular posterior rhexis. Because once you have a regular round rhexis, or even if it's not completely round, provided it's not weak, it doesn't have any areas that can spread out to the periphery, you have a very stable so-called incomplete bag, as you can see here. After which, the ideal lens which should be used in this, which is being used, which is a 3-piece Alcon lens. When you use a 3-piece lens, those rigid haptics go and sit properly in the confines of the bag. These lenses, pushing in the second haptic can sometimes be a little challenging. It's worthwhile using a pusher here to just flex it in place. After which the rest of the viscoelastic is removed, and then the surgery is pretty much the same. And well, it isn't over till it's over. In these polar cataracts, you should be very cautious. See here on the left now, when the surgeon goes ahead to do, who did the stromal hydration, right now created an opening in the posterior capsule as a result of excessive pressurization of the globe, which was noticed only on the next day. So even the last step of stromal hydration should really be rather carefully done. Yeah. And finally, the last video I'd like to show, this is a case of a post-vitrectomized eye, and there is some silicone in the anterior chamber. And it's a very soft cataract. Surgeon proceeds with going ahead and removing the nucleus to find there is that dense opacification in the posterior capsule. So at this point, the surgeon decides that probably it's be quite, just perhaps try to go ahead and remove that opening in the posterior capsule. So this is an induced opening at the end of nucleus management. Once the epinucleus and the entire nuclear material is out, the surgeon actually notices that dense opacity there and proceeds to just make an opening in the posterior capsule and turn it around gradually and slowly. At that point, we just couldn't find the intraocular forceps, so we managed with the cystome itself. It was torn out and made into a reasonably circular opening. After that bit that was turned out was pulled out of the eye under viscoelastic, and finally an IL was placed within the confines of the capsular bag. So these are my experiences with all these, which I wanted to humbly share with you. Thank you very much.
Thank you, Dr. Suveera. Excellent videos. And just by the time what would be your choice of lens? How would you decide when to do what?
I think this tremendous sense is we don't know how we're going to end up. So I think in our hands, in our center, our rate of opening in the roughly about 10%. But you don't know which one. I know that the classic looking, the thick onion pearls with the radial spokes, cortical spokes with vitreous opacity signify possibly it could happen. But there can be an odd case where you're manipulating a little more, wo nucleus chop nahi hua. If you have some such things, it can open in any case. So we now keep a 3-piece IOL standby always. And when we do that, we take into consideration that since this lens is going to be in the sulcus as opposed to in the bag, we account for that and make it about 0.5 diopter more myopic.
So if you're actually going to the sulcus, any other, would it be just a plain sulcus fixated, or would you like to do a capture?
Yeah, I would put, see, look, if I've got a stable bag still and a nice small intact rhexis, my first choice would be to put the haptics in the bag and do an anterior optic capture.
Okay.
Should I not have, it looks really funny behind there, then I might actually put the IOL in the sulcus and do a posterior optic capture. So those would be my options, but a 3-piece lens, stand by it now always, I guess.
Thank you.